forgot ta, for nakalimot ta og pray before mag-start. It's against na mag-lead sa prayer. Ikaw,
Hindi.
ah, morning. Sige, ikaw na lang, Rashid, Pera.
Yes, Doc.
Sige, sige.
Okay. Guys, let's pray. Lord, thank you for this wonderful day. As we start our class, give us knowledge and wisdom. Forgive us from all of our sins. In Jesus' name we pray. Amen.
Amen. Okay. Okay. Can I be heard naman, no? Loud and clear, ah.
Yes, Doc.
Okay. Okay. Sige, so this morning, no, so let's continue the discussion on uh, disorders of the GI tract in children. So first is discuss on the congenital disorders, no. So number one is esophageal atresia and the tracheoesophageal fistula. So esophageal atresia is the most common cause of congenital anomaly in children, and more than 90% of these of esophageal atresia is associated with TEF. Okay, and also 50% of these esophageal atresia is associated of what we call the Vactal syndrome, which involves the vertebra, the anorectal, the cardiac, tracheal, esophageal, renal, radial, and the limb. Okay, so it's not quite common, no, and hopefully you'll be able to see such patients, no, when you rotate in your clinics, no, or in the hospital para mas ma-appreciate ninyo sad siya. Okay? Anyway, so these are the types of esophageal atresia. So types A to E. So take note, no, of the most common one, which is the type C, okay, which is the wherein there is the presence of esophageal atresia with a distal TEF, no, trachea connecting with the distal part of the esophagus. So anyway, the type A, 8%, no, prevalence. There is only atresia. So this is the isolated esophageal atresia type A. There's no fistula. And then the type B, so not very common, no? So there is atresia plus a proximal TEF. So the type C, so I've mentioned that. Then the type D, it has both the proximal and the distal fistula. While the type E, so parang ano siya, hindi siya ano talaga, esophageal atresia because there's no presence of esophageal atresia, but just a TEF lang. No, but still it's part of the types of esophageal atresia. So this is what they also call the H-type fistula, okay, which is present in 4%, no, in this age group. Okay, so the cause for esophageal atresia is still unknown. However, there are associated risk factors or features, no, as shown in this slide, no. So mothers who bore children with mothers with advanced age, no, who bore children may have this esophageal atresia. Those with European ethnicity, those who are obese, low socioeconomic status, and chronically exposed to tobacco. So for presentation, so this is very typical of esophageal atresia, no? The frothing and bubbling at the mouth, no? However, for the H-type fistula, since it doesn't have an esophageal atresia, so the secretions will just directly go down, no? Down to the GI tract. However, the manifestation of H-type fistula, it's more of a recurrent respiratory symptoms, no? Especially pneumonia, no? So you have to consider this H-type fistula in those babies na mag-on and off ang ilang pneumonia. Okay? So aside from that, aside from the frothing and bubbling of the mouth, so they would also have bouts of coughing, even cyanosis, no, and distress. So you have to be very vigilant, no, in diagnosing this to prevent the onset of aspiration and pneumonitis. So the only way to diagnose, so actually you can diagnose it clinically with the frothing and bubbling of the mouth. And if you are really that suspicious of esophageal atresia, you can try to insert an NGT or OGT through the stomach, and failure to pass through towards the stomach may indicate the presence of esophageal atresia. Okay. Perinatal ultrasound may be also helpful, and we can detect their polyhydramnios, no, and an absent stomach bubble. So that's suggestive of esophageal atresia. And on radiographs, um, you can see that the tube, the OGT or the NGT tube is coiled, no, at the is where the esophageal atresia is present, no, or at the pouch, esophageal pouch. And then you can also see an air distended stomach, especially those with TEF, because the air from the lungs will uh, go down towards the stomach. And for those with pure esophageal atresia, so there's no fistula, so you would see there is an airless or scaphoid abdomen. So you can see this picture in your Nelson's. So I'll just show to you know what an coil tube looks like, no? So this is a patient with esophageal atresia. Okay, and this one is the H-type fistula, no, as demonstrated in an infant during a barium swallow. So barium swallow ang gi-perform aning a patient, and you could see this is the trachea, and this is the esophagus. So the barium, no, a small amount of barium went through the, what do you call this, the trachea, no. So that suggests an H-type of fistula. So management, so initially you have to maintain a patent airway, okay? And then you decompress also the proximal pouch or the distal pouch, no? And then to prevent aspiration, no? So you have to really remove the secretions. Then you have to give also antibiotics to prevent the onset of pneumonia. And then prone positioning will minimize also the movement of the gastric secretions towards the fistula, no, or towards the lungs. And then endotracheal intubation should also be avoided, no, because it may worsen the distension of the stomach, no, especially if there is presence of fistula. Okay. So, so of course, the treatment for this is always surgical, no? So first they have to, there's what we call primary complete repair and stage repair. So for primary complete repair, so fistula is ligated and the esophagus is anastomosed, no? But for high risk patients, so usually um, the procedure is uh, these steps are not done together, no? So initially, ligation, lungs, fistula, or even ano pa, mag-placement sa sila o gastric tube, ipastabilize sa ang patient, no? And then thereafter, around 3 to 6 months after, or when the child is physically fit already, esophageal anastomosis can be done at a later date na. So survival rates, no, it's very good naman, above 90%, because of the improvement of our neonatal care, and then because of early recognition and appropriate intervention done. Okay, but exemption for babies who are born with very low birth weight and those with cardiac anomalies, they may have a poor prognosis, no? They may have difficulty recovering from the condition or even from the surgery. And the things to watch out for, um, Post-operatively, no, are the following. So anastomotic leak, refistulization can happen, anastomotic stricture, reflux disease, no, since there is a manipulation of the esophagus, no, or surgery was done at the esophagus. So you would expect there's a high chance of developing reflux disease in these patients. And also tracheomalacia, no. Next congenital disorder is the hypertrophic pyloric stenosis. So it occurs in 1 to 3 per thousands of infants in the US. So it's more common in whites, 4 to 6 times more common in males. And also for mothers who had a history of pyloric stenosis may have children, their children may have a higher chance of developing pyloric stenosis than those fathers with a history of pyloric stenosis. So the same, no, with esophageal atresia, the cause is also unknown, but there are associated conditions, no, that may come with the pyloric stenosis, such as the following. Okay, risk factors also like the giving of erythromycin within the first 2 weeks. So you should recall, no, the intake of these medications when you are presented with a baby with vomiting, no? Projectile vomiting. Female infants of mothers treated with macrolides, and also those with abnormal muscle innervation. Actually, this is the of the pathophysiology. For presentation, so it should always be non-bilous vomiting since it's the obstruction is at the pylorus, and then it should be projectile, and usually it's postprandial. Okay. So presentation usually after 3 weeks of age, but it can occur as late as the 5th month of age. So it's still a differential diagnosis, no, even if the baby reaches around this age. So you have to be uh, careful, no, for this complication, hyperchloremic metabolic alkalosis, no, if there is a continued vomiting, no, in these patients. And then so this is the atypical presentation of some children with pyloric stenosis. So intermittent emesis with rapid improvement after hydration. Um, so there is also some children with pyloric stenosis may develop jaundice as well, no? Also known as icteropyloric syndrome. So due to the decrease in hepatic glucuronyl transferase activity associated with starvation. So you would see an elevated unconjugated bilirubin or indirect bilirubin in these patients. So the improvement will be dramatic, Raman, no, after the correction of the stenosis. So so for very thin patients, you may easily recognize this olive-shaped mass, no? Usually found at the mid-epigastrium. Okay, and it can be best palpated after an episode of vomiting. And sometimes you may also appreciate this peristaltic wave. Okay, especially after feeding the child. Wait, wala. Anyway, so so to confirm the diagnosis of pyloric stenosis, you can do the ultrasound, which has around 95% of sensitivity. Okay, so these are the criteria, no, for the pyloric stenosis, the thickness, the length, and the diameter. Okay. So as you can see here, no, para siyang ano. So here in the transverse sonogram, so this is the you can it will be the thickness of the pylorus is demonstrated, and the horizontal view ang iyang length niya. Contrast studies may also confirm the diagnosis, no? And usually the following signs can be seen, no, with this test. So number one, this an elongated pyloric channel will reveal a string sign. Okay, so this one string sign, then the bulging of pyloric muscle into the antrum, so that's the shoulder sign, and parallel streaks in the narrow channel. So it's not that visible. It's not seen here, no, the parallel streaks in the narrow channel, or double track sign. So for treatment, so you have and check if there is acidosis or alkalosis, and then you correct the electrolyte imbalances. And then of course you have to put the patient on NPO and insert an OGP, no, to prevent the risk of aspiration from the gastric contents. So surgery must be done immediately. So the pyloromyotomy, and for others, conservative management are initially done first, no, while stabilizing the patient. So these are usually what is done, no, as conservative management. So it's highly curative, no, with surgery, with very, very low mortality rate. But you still have to observe the patient for post-op vomiting, okay, which suggests an incomplete pyloromyotomy. Perhaps there's gastritis or reflux disease, and so you can give a proton pump inhibitor for these cases. And in some cases where incomplete pyromyotomy happens, so a balloon dilation via endoscopy may be done and is proven to be successful. Next congenital anomaly are the atresia and the stenosis. So atresia, so it means there's an uh, absence or there's a pathologic closure of a body opening. Okay, while stenosis is just a narrowed lumen. So there's no total obstruction there yet. Okay. So in the GI tract, no, so 90% of atrecias may be found at the at the small intestine, no, particularly at the duodenum. And then the most common cause is usually the duodenal atresia, no, which results from a failed recanalization of the intestinal lumen. Whereas for jejunal atresia, the cause is more of a vascular, intrauterine vascular accident, no, and it's not associated with extra-intestinal anomalies like the duodenal atresia. Okay, so as you can see here, so ang most common here are the type 1 and type 3A jejunal atresia. Okay, so for duodenal obstruction, so again, most commonly is the duodenal atresia, present around 2.5 to 10 per 100,000 live births. Okay, and other causes of obstruction could be there is a mass or something that's bulging around the duodenal atresia, no, an annular pancreas, the pre-duodenal portal vein, no, this may compress the the duodenum, okay, resulting to obstruction. So as I have mentioned, so duodenal atresia, so this is due to failed recanalization. Failed recanalization of the intestinal lumen during gestation. So usually this should happen around ninth week, ninth week of life. But during this stage, no, if there's a halt in the recanalization, so this will happen. Okay. So very common in patients who are premature and those with um there's also presence of other congenital anomalies like in Down syndrome. For duodenal stenosis, so as I have mentioned, no, so incomplete lang ang recanalization niya. So ang symptoms sa duodenal atresia versus sa pyloric stenosis kay pilus vomiting siya, no? In the absence of abdominal distension. Okay? And on ultrasound, we can appreciate as well, no? Polyhydramnios. So, tanan mga GI tract obstruction, you expect polyhydramnios there. And then peristaltic waves may also be seen, no? And jaundice can also be present in these infants with duodenal atresia. So there na video there peristaltic wave. There you see that, no? So so we can appreciate that too in duodenal atresia. And also, so you can also see, no, in X-ray the double bubble sign, no, which is the hallmark of duodenal obstruction, no. And so with this finding plus bilous vomiting, so most likely the patient is having duodenal obstruction. Okay. With contrast naman, so it can be done also, no, just to rule out volvulus or malrotation, which may also present with um, bilous vomiting, no? Next is also prenatal diagnosis, no? Actually, the double bubble sign can also be seen, no, with prenatal ultrasound. And it's important din, no? That's why prenatal ultrasound is important, no? So, para ma-advise na to ang parents, a mother, or yeah, parents, what to expect, no, when the child is born, no? And what are and ma-plan ahead, no? What the things that should be done. So for management, so again, it's an GI obstruction, so you have to decompress. So you have to insert a tube, no, a gastric tube. And then IV fluid hydration should be done. And since these cases is children with duodenal atresia um, may have a concomitant congenital anomaly, so you have to also screen the patients, no, for these, no. So you can request for ECG, renal ultrasound, or X-ray of the chest and spine. Then surgical treatment, so surgery like gihapon and treatment, no. So duodenostomy and insertion of gastric tube feeding. Next, another common congenital anomaly, the Hirschsprung disease. So it's the most common cause of lower intestinal obstruction in infants rather. Um, and then it's present in 1 in 5,000 live births, no? And the other term for this is the congenital aganglionic megacolon. So there are many types, no? We have the okay, it's more common in males, gihapon, no? With 4:1, 4:1 na rate for short segment and 2:1 for the total or the long segment Hirschsprung disease. So for long segment Hirschsprung disease, so usually it's familial. So there is a history, no, that a family member had the same problem, no. Again, more common though, it may be associated with congenital anomalies like Down syndrome, neurofibromatosis, neuroblastoma, etc. Okay. So yeah, so here are the types, no. So we have the short segment, the rectal or rectosigmoid involvement, and the long segment, no, beyond the sigmoid. So you can these are characterized. This is a character I describe as a long segment if the involved intestinal segment is beyond the sigmoid. Total, no, if it includes the proximal portion of the intestine and the terminal ileum, and extensive if a significant portion of the small intestine is involved or is affected. So Hirschsprung's disease is a consequence of an arrest of neuroblast migration. So with that arrest of migration, which happens from week 8, um, there would be absence, no? So usually it starts from the anus going to the proximal, no, proximal portion of the of the GI tract, no? So that's why um for those na ano, ang arrest kay mag-start siya earlier, so pwede mas mahaba yung ano niya. Ano, short segment lang siya. Okay, but then with that absence of ganglion cells, so there would be inadequate relaxation since these nerves are responsible for the relaxation and contraction of this of the intestine, no? So kung wala ang absent ang ganglion cells, so chronically contracted ang imuhang intestine. So it will not ano siya mas stretch, no? So it will become hypertonic and this will um result to obstruction, no? Or functional obstruction. So manifestation, so you would expect sa history nga na delayed passage of meconium. So this time the abdomen would be distended, no? Since it's a lower GI tract obstruction. So for lower GI tract obstruction, usually what happens first is distension of the abdomen, no? Followed by emesis. Versus those na sa upper GI part pang obstruction, vomiting yun na ang initial presentation. And um, distension usually does not happen. And because of the distended abdomen, so there could be feeding intolerance in this patient. There, of course, with chronic constipation, and then the enterocolitis, no, which is the dreaded or life-threatening complication of Hirschsprung, otherwise termed as Hirschsprung's disease-associated enterocolitis, no. So the manifestation, so the child will develop diarrhea with tender abdomen, fever, and signs of bowel obstruction. Okay, so we have here the grading of the HAEC or Hirschsprung associated enterocolitis. So you just take note of that. And depends on the grading of the HAEC, um, the management would also differ, no? So in cases with short segment Hirschsprung disease, so well, usually in patients with long segment Hirschsprung disease, the onset of symptoms is very early, no, even in 1 month of life. So they would manifest right away with with abdominal distension, vomiting, no. But for children with short segment Hirschsprung disease, their manifestation may ano pa comes in a later date pa. So that's why some of these patients maybe can be mistaken as a case of functional constipation. So therefore, it's really important that you you can distinguish it with um, functional constipation, no? So you have to inquire the onset of constipation, whether it occurs earlier, no, less than 6 months of life, or even at birth, no, wherein a delayed meconium passage was documented. Okay. Encopresis or fecal incontinence does not occur in Hirschsprung disease. So this one, no, failure to thrive, enterocolitis or diarrhea with fever and abdominal pain. So that can be easily seen with in Hirschsprung's disease. There's abdominal distension, so not quite common in functional, but very common in Hirschsprung disease. Poor weight gain in Hirschsprung's. When you do your DRE, you don't expect the presence of stool in your examining finger. And when you remove your examining finger, there's an explosive passage of stool, no? Noted in patients with Hirschsprung's disease. As mentioned, no, so malnutrition or failure to gain weight, no, is present. And in children with Hirschsprung disease. And then on investigations, so although this test is not um, commonly found, no, in our setting, So manometry may show this finding, no? Failure of internal anal sphincter relaxation. And for definitive diagnosis of Hirschsprung disease, so biopsy will show no ganglion cells. And on barium enema, so there's a transition zone that can be seen, no? Versus that of the functional constipation, there's no transition zone. You can just appreciate fecal stasis, no? So for diagnosis, so of course, no, have the patient, ano, undergo biopsy, no, rectal suction biopsy. So as you can see in this image, so you would see that there's absence of ganglion cells, no. This one in letter A, this is a normal colon with ganglion cells. Letter B, wala. There's no presence of these ganglion cells. Okay. So there, no? So muna yung mga pathognomonic findings, no, sa Hirschsprung disease. Absence of Meissner's and Auerbach's plexuses, hypertrophied nerve bundles, and high concentrations of acetylcholinesterase. Okay. Um, ah, yeah, just one question. So where do you see the Meissner's gani? Which layer? Meissner's plexus? If you can recall sa histology, anyone? Which layer man sa yung mga intestinal mucosa ang Meissner's plexus? Manawag lang ko be. Si sino ito? Let me call Boyser. Grant Boyser. Ay, nawa man. Akire Alora. Na si Alora. Akire. Ay, wait lang. Yung nag-chat.
Ito,
Ah, sorry. Karoon ako kabasa.
the dermis
Sorry.
of the
Yeah.
mucosa.
Okay. Yeah, that's correct. Sorry naman day message group chat eh. Anyway, yeah, sa mucosa. Yang Auerbach's kay sa muscularis. Muscularis layer. Okay, so what we do initially for patients whom we suspect Hirschsprung disease, we initially do barium enema and try to see if there is the presence of transition zone. No? So as you can see in these pictures below, so would see a dilated proximal colon and a small caliber obstructed or ganglionic segment. And this one is the transition zone. No? There's sudden dilatation. Okay. So, and then also, we can also measure no, the rectal sigmoid ratio diameter. So if it's equal or less than 1, then this is already suggestive of Hirschsprung disease. Because normally, the rectum is larger, no? But if mas smaller si rectum, so suspicious of Hirschsprung disease. And if ever, ano gid siya, suspicious gid siya, then we will refer the patient sa surgery to do the the biopsy, and then once confirmed, dire-diretso na siya i-surgery, no? So what's usually done is the primary pull-through procedure, no? So usually i-cut lang to siya ang segment, uh, the segment wherein there are no ganglion cells, and then i-anastomose yung mga healthy parts of the of the intestine to the rectum. Okay. So but for those with yeah, this is the same. This is for the HAEC, no? HAEC, Hirschsprung associated enterocolitis. So as you can see here, no, depende gyud ang depende sa grading ang treatment, no? So usually what antibiotic, we initially put the patient on NPO, no, especially for if it's really a confirmed HAEC, no. So we give metronidazole and other broad spectrum antibiotics and do regular rectal irrigations. Okay. And for those na very severe ilang HAEC, so we do a proximal diversion. So hindi siya agad, primary pull-through is not yet immediately done for these patients. So usually do colostomy lang sa, and then await for the inflammation to heal, no? After several months. And once completely healed na siya, then the operation may be done. For the prognosis, so generally satisfactory. Most of them will achieve fecal continence. However, you still have to watch out for the following long-term complications, no? So the patient may still have symptoms of constipation or even HAEC, no? Postoperatively, they may also develop HAEC. Perhaps wala siguro na completely remove yung aganglionic segment, strictures or prolapse and abscesses may also happen, no? So follow-up is really, really important, no? Especially in the first few months, no? Post-operatively. So now let's go to pediatric emergencies, no? Gastrointestinal emergencies. So foreign body ingestion. So very common in children, no? Especially at around 6 months to 3 years of age, no? Where these children tend to explore much, no? So these are the most commonly ingested objects, the coins, small toys, no? And more frequent among those who are developmentally delayed, those with psychiatric disorders. So if we encounter such patients in the future, we really have to advise the parents, no, uh, to keep the small objects away, no, out of their reach. Okay, because they are the population, no, at risk for foreign body ingestion. um Okay, so history is very important because some of these patients may be asymptomatic, no, initially. And that's why it's very important, no, pag in any nga age group, there should always be someone, no, with them, no, especially when they are playing, no, with their toys. But for those who are symptomatic, so they would have presence of wheezing, stridor, cyanosis, no, if obstructed kud ang airway pod nila, and dyspnea. Okay. Some of them will have cervical swelling, erythema, or crepitations, especially for sharp objects, no, which causes perforation, no. So they will also have those symptoms. Um, so these are the areas, no, where the foreign body will usually get lodged, no. So mga narrowing nga areas. So cricopharyngeus, aortic, where the aorta crosses over, and the lower esophageal sphincter. Okay. So for diagnosis, so we can request for X-ray, no, sa neck, sa chest, and sa abdomen. And then we can do also CT scan and barium studies. However, we should be careful, no, with this one. Vaccine mag-aspirate patient, no, with the barium studies. So this one, as you can see here, no, so this is a child, no, nga na ay what you call this, ingestion. Okay, so there's a foreign body lodged in the esophagus. So usually the flat surface of the object is seen on the anterior posterior. Okay, and the edge is seen in the lateral view. This one. Pero if the object is at the trachea, opposite siya, bale sa anteroposterior, ang lateral side sa coin makita, and sa lateral view, the front of the coin is seen. So if it's lodged in the in the trachea. So treatment, so endoscopy should be done, no? Depende actually on the urgency of the case, no? So, however, if the foreign object is in the esophagus, so it should be, removed within 24 hours. But if ever the foreign body has passed through the esophagus, it's already in the stomach, and the child remains to be asymptomatic, so the child may be observed, no, for spontaneous passage of the foreign body, but for the coin lang siya. For the blood, only for blood objects, but for sharp objects, it's important na they have to be yun siya, removed, no? And for those who have symptoms, no, it should be removed as well, no? So don't observe patients who are symptomatic. Another common emergency is caustic ingestion. Um, so caustic ingestion around the same age group pa rin, no? Those less than 3 years of age, and mostly accidental, no? Um, so these are the agents commonly ingested, mga alkali, which comprise 70% of ingestions, and the acid, no? So, um, so nowadays, parang increasing, dili na accidental, no? Ang causes usually parang deliberate na intake na, especially for the older age group, no? We're seeing many patients already, no? Trying to commit suicide, no? With these caustic substances. As to the effect, no, in the GI tract, no, versus as acid ingestion versus alkali. So for acid, so there would be a coagulative versus the liquefactive necrosis of alkali. For acid, there's formation of eschar, but with lesser perforation versus that of the alkali. Okay, and then predominantly the locations of injury happens at the stomach if acid was ingested, more on the esophagus if it's alkali. So symptoms of caustic ingestion, so vomiting, drooling, refusal to eat or drink, dysphagia, no? Dyspnea, abdominal pain, hematemesis, no? Presence of three of these symptoms, no, would suggest a severe lesion. Okay. For signs, so you would expect, no, mga lesions sa mouth, but if absent na siya, doesn't mean that there's no injury beyond it. So you still have to consider the symptoms, no, if there is really a history of intake, or if someone saw the patient, no, in having ingested the caustic substance, so endoscopy should be done, no, to check on the degree of injury of these patients. So for management, so before, no, it was some do induced emesis, gastric lavage, or take in mga milk just to neutralize the caustic substance. But now it is not recommended nor even contraindicated, no? So what we usually do is just put the patient on NPO, put them on acid suppressants, put them on antibiotic, no? Especially for those with severe symptoms, no? And do endoscopy so that we can grade the injury, no? So so in terms of grading, so these are the classifications of grading, no? From grade 0 to 3. So uh, so the reason why we have to do this is that para ma-prognosticate na to ang patient, no? Say for example, for patients with grade 2B, so those with grade 2B and above, they are the ones that will have a high chance of developing esophageal stenosis, no? Weeks after the ingestion. So we have to advise them that to observe for the presence of dysphagia or intolerance to food, no, or chest pain, no? Because usually stenosis could happen around 2 to 3 weeks, no, post ingestion, no. But whereas for those with grade 0, 1, or 2A, usually there is no long-term out sequelae for these type of injuries. Okay. Now it's another emergency is the intussusception. Ayan, so intussusception, so it's the invagination of one segment of the intestine into the lumen of an adjacent intestinal segment. So we have two terms here, the intussusceptum. So this is the one that the advancing proximal intestine, and intussuscipiens, which is the distal recipient intestine. So mo ni siya ang movement, no, sa intussusceptum, intussuscipiens. It's the most common cause of intestinal obstruction at this age group, 5 months to 3 years of age. Usually occurring, 80% occurs no before 24 months of age, but it's rare in the neonatal age group. Okay. Again, male is more predominantly affected, and the most common locations is at the ileocolic, no, ileum and the colon, ascending colon. So 90% of cases are idiopathic. Okay, so while the remaining percentage has a lead point, no, such as the hypertrophied Peyer's patches, secondary to infection, or the presence of microdiverticulum or polyp, or any masses, no, in the intestine can serve as a lead point, no, for development of intussusception. So for presentation, so typical presentation, so in a previously well child suddenly experiences severe colicky abdominal pain and becomes irritable. So parang on and off siya, sudden pain, then the child suddenly looks active, no, as if nothing has happened, no. So there's paroxysms of pain and playing normally. However, when this intussusception if becomes persistent and immediately not being it's not catched, no, the diagnosis is not um done early, so it will lead to complications, no? So from irritability, the child may become lethargic already, they would be weak, even the presence of bleeding because of the compromised blood vessels in the intestine, and worse is the development of shock, no, and peritonitis. So you really have to catch early, no, the intussusception, no, while the child is not yet in shock. Okay, um, so you have to have this triad, no, to at least have a strong suspicion of intussusception. So if you in a vomiting child with abdominal pain, you have to try to palpate, no, for the presence of the mass, no, or the sausage shape mass, no, of the intussusception. And then so that's 90% already, no, sensitive for your diagnosis of Hirschsprung. But if with rectal bleeding na gani, so that's highly suspicious na of intussusception. However, in large patients or those with belly fat, so it's quite difficult to do appreciate palpable mass. So sometimes or more often than not, we really have to do imaging in these patients, no, like ultrasound, which is very sensitive and specific, and we can appreciate the target sign and the pseudo kidney sign, no, on the longitudinal view. Barium enema can also be done, no, and you would appreciate a coid spring appearance of the barium. Okay. As to the treatment, so there is a small percentage of them will spontaneously resolve. Okay, but others we have to do some interventions, no. So for conservative intervention, meaning surgery may not be done, usually is not done. We can do radiologic reduction, no, or hydrostatic reduction, okay, which is around successful in 80% at least, no. So what is done? What is that? So here, so this is sa A, this is the part where there is intussusception, and with the hydrostatic uh, reduction, so parang na push ra ang kato intussusceptum, no? And then there's already a flow of the contrast. However, in cases there's already shock, no, there's suspicion of necrosis or perforation or peritonitis, no, if the abdomen is already tender, then surgery should be done already, no. And also for those patient who underwent conservative treatment but intussusception recurred, so then surgery is already indicated for such cases, no? With surgical reduction, so there's a low chance of recurrence rate, but for those who are managed conservatively, we really have to observe them for the first 3 days, no, because there is a chance of recurrence rate, no. So observe usa, no, if conservative management is done. So multiple recurrences is observed, no, in patients with dead point. So surgery should be done, no, therefore in those patients with recurrent intussusception. Meckel diverticulum, a most common cause congenital anomaly of the GI tract, and is caused by the incomplete obliteration of the omphallomesenteric tract at the 7th week of gestation. So there's what we call the rule of twos, no? Wherein which can serve as a guide, no, for us to suspect Meckel's diverticulum. So usually it occurs at 2% general population, symptomatic before age of 2. Again, common in males, so low kay ang males, no? And then usually the diverticulum is located 2 feet proximal to the ileocecal valve, 2 inches in length, and there are two types of mucosa present in the diverticulum. Okay, so, and then for presentation, so intermittent painless rectal bleeding. So take note of the painless rectal bleeding. And the color of the stool is brick colored or maroon colored stools. So they may appear red or even black, no, for those with slow bleeding Meckel's diverticulum. And as I have mentioned, the diverticulum may also serve as the lead point for developing intussusception. So bowel obstruction may be the manifestation of Meckel diverticulum. Pwede dili siya bleeding. Pwede obstruction iyang manifestation. So these are just the differential diagnosis for children with GI bleeding, no, depending on their symptoms, no. So for unwell babies, so definitely you have to consider Meckel's diverticulum, no, for those young children. Okay. But for those well babies, so usually the cause for that is just allergy, no, or infection even. Okay. But of course, for again, as I have mentioned yesterday, for those with GI bleeding, always rule out infection first, no, before you consider also other etiology. But of course, you have to also consider other symptoms, but no, or review the history to come up with a definitive diagnosis. So to confirm the presence of Meckel's diverticulum, so you can do the Meckel's radionuclide scan. So we're in the technetium 99M, easily absorbs, no? Is easily absorbed by the ectopic, the Meckel's diverticulum. So this one, usually this is it becomes positive lang, no, if the Meckel's diverticulum is rich in gastric mucosa. However, for those with predominant pancreatic mucosa, the Meckel scan may be negative. Okay, so there. So that's how you diagnose Meckel's diverticulum. So once confirmed, so diverticular diverticulectomy is done. Okay. For those who are asymptomatic, so the benefit of removal outweighs the risk of complication. So even if incidental lang siya na finding, you still have to remove it. No? For acute appendicitis, so it's the most common surgical condition in children and a major cause of morbidity. And 1 to 8% of them will present in the emergency room. So usually the incidence is around at this age group, no? Can 10 to 18 years of age. Okay, so it has a low mortality rate, but morbidity remains high, mostly um, those with sige yung PA. Sorry, I did catch the PA. Anyway, ano ata to, those with ano na perforated appendicitis or those kanang ruptured na appendicitis. Next is pathophysiology. So, of course, no infection, genetic or environmental may also play a part, no? So, what happens in appendicitis? So, it usually starts with obstruction of the lumen of the appendix, usually with fecal material, but others pwede mucus, pwede siya maka-obstruct, no? So, kana, no? So, with that, so there would be, or even kani mga tumor or parasites, pwede siya mosulod diha sa lumen. And once the lumen is obstructed, mag-increase ang intraluminal pressure, there would be congestion of the lymphatics and vein, impaired arterial perfusion, and then bacterial proliferation and invasion of the wall will lead to necrosis. Okay, so the classical presentation of appendicitis is onset of pain initially at the periumbilical or the mid-abdomen, and then it migrates to the right lower quadrant. However, this may not be present in all patients with appendicitis. So you have to do a good history and PE for these patients, and if you're really that suspicious, so imaging can really help to diagnose appendicitis. Okay. So there, no? So for the presentation, initially, the patient may just manifest with nausea or anorexia and malaise. And then the progression usually starts at the next 2 to 3 days. And then beyond 48 hours, perforation may happen. So yun ana kapaspas siya, no? So in the early appendicitis, the abdomen is typically flat, no? Abdominal suggestion already suggests an advanced disease and characteristic already of obstruction or even perforation. Okay, so localized abdominal tenderness, so very reliable. So you really have to do a good physical exam, no? So direct tenderness in the right lower quadrant, presence of psoas and obturator sign, no? So you have to practice those technique, no? Para ma-diagnose early on ang appendicitis, no? So also we have this Dunphy sign. So any sudden movement like coughing or the will elicit pain, no, at the right lower quadrant sign. So that's Dunphy. So we have this pediatric appendicitis na scoring, no? So we can use this, no, for scoring. So ang score ani niya if it's more than if it's 8 and above, so you should be highly suspicious. That's already sensitive and specific for appendicitis. But if 4 low, so there's a low likelihood of appendicitis. Okay, so fever, anorexia, nausea, migration, leukocytosis, and neutrophilia. So 1, but if right lower quadrant tenderness and with the uh, pain with movement, so that's already both of them scores 2, no? So yeah, you can do that actually, no? When you when you see the patient, no, in the ER baron or in the wards, you can elicit that. So as to the imaging, so the first choice would be ultrasound. However, it's not really that, although it's 90%, but sometimes it may the appendicitis may not be easily appreciated no with ultrasound, especially for kind of with thick abdomen, those who are overweight. So it can be hardly seen, no? So these are the signs, no, of appendicitis, the target sign, very appendiceal fluid, and a dilated non-compressible appendix. And that's why if the gold standard should be the CT scan, which is very sensitive and specific, no? Although it's more costly than ultrasound, but if we are really that considering appendicitis, then CT scan should be is the best thing to do, no, to diagnose appendicitis. So if we consider appendicitis, so we should immediately start antibiotics, no. So we can start with piperacillin tazobactam, no. Okay, and for complicated appendicitis, those with suppurative or ruptured appendicitis, you can extend the antibiotic, no, via IV for 2 days. And then if the patient is already being fed, so we can shift that to oral antibiotics. Once the diagnosis is confirmed or highly suspected, so surgery should be done immediately. Okay. So there's a laparoscopic appendectomy, which is a preferred surgical treatment. However, not all surgeons are not capable of doing so. But with this technique, so early ang recovery sa patient. No? For non-surgical management, so it can be done, no, for patients whose symptom duration is less than 48 hours or more than if they are more than 7 years of age. And via imaging, the appendiceal diameter is not that dilated, no? Or if there's absence of these and the WBC is not that high, so it can just be managed conservatively, no? Maybe they can just be given antibiotics, but of course you really have to advise them, no, to come back right away, no, if there's recurrence of symptoms or even persist ang symptoms despite the conservative management. Okay, so that ends my lecture for this day. Do you guys have any question?
None so far, Doc.
None ra? Sorry ha if medyo pas-pas kay napa ko endoscopy later. Sige, wala na no question ra?
None ra, Doc.
Okay, sige. Hopefully nara mo na learn. Okay,
Thank you, Doc.
thank you.
Thank you, Doc.
Good luck sa exam
Thank you,
tomorrow.
Doc.
Sige, sige.
Thank you, Doc.
Bye-bye. Wala dito nagpicture. Okay ra ba?
Okay ra, Doc. Kaya nara may katong
Sa
G4.
Zoom? Okay, okay. Sige, sige. Thank
Thank you,
you.
Doc.
Bye-bye.
Thank you, Doc.
Thank you, Doc. Thank you, Doc.
Thank you, Doc.